Rahim. So yeah, and I need to finish infective disorders today and geriatrics if possible. A few topics are there that I just want to just finish it off very fast. Um, then stroke on cerebral accident also I want to finish off as much as possible because stroke is a very important topic. So yeah. Mm, hmm. Okay, so I have listed out all the topics that are fever and typhoid fever, character is UTI and all pattern. You have to see these types of patterns. Sustained or persistent typhoid, intermittent is malaria, leishmaniasis, saddleback is this thing, recurrent is shortkins, and precedented dental extraction. If there is there UTI catheter is there, in fact, it is UTI. If dental extraction, then it's infective endocarditis, associated blood bowel movement. All of this indicates some or the other type of symptoms. You review the past history, past surgical history, drug history you give, immunosuppressants, anticoagulants, drug fever if it's there, allergic reaction after fever. If you take any drugs, and family history and social history you can take. Physical examination, you can examine every single part of the body, head, neck, lymphadenopathy, everything. Just write on your own how much ever you can. Head you can check, feel everything, pattern of illness, feel or not ill by epitom clear x-ray notes and all lymph nodes you check, all do everything. Skin tests you do, peripheral smear, ESRP, ILFT, RFT, blood, serum virology, urology, whatever name you can think of, you have to write everything. Laboratory, electrophoresis, CT, and antibody, ECG, thyroid, bone marrow, lumbar. Just keep on writing. I'm just yapping here. Radiological investigations also same, CT, PET, everything. And treat the underlying cause, broad spectrum antibiotics, the aspirin and steroids, and an naproxen challenge for empirical anti-TB treatment. And that's how you treat pyrexia of unknown origin. That's it. So after I erase all this, on with leishmaniasis, which is a leptospirosis, which is the first question. So bacterial infection, scarlet fever, no one asks. Streptococcus, no one asks. Pneumococcal, yes, they do ask. But do I have it right here in my list? No. So I'm not going to do it. Diphtheria, yes, diphtheria is one small topic. It's a nasopharyngeal skin infection, cutaneous diphtheria, nasal-respiratory diphtheria caused by convective diphtheria, gram-positive bull neck appearance is there, husky voice. Cutaneous diphtheria, uncommon. Round, deep, punched out skin ulcers and the manage covered by green grass, a brownish adherent. Ulcers are commonly on the lower and upper extremities. Same things. Complications, we have airway obstruction. First of all, it will appear as either pseudomembrane extension or due to tracheobronchial tree bronchopulmonary diphtheria. Children, because of small airways, it's more common. Cardiac complication, you have myocarditis with arrhythmia, cardiac failure, ECG changes. After weeks of exposure to diphtheria, it's usually changeable. Neurological complications, 75% of the cases, palatal paralysis, polyneuropathy, paralysis of the accommodation, making it difficult to read fine print, and encephalitis rarely. Pneumonia, renal failure, encephalitis, cerebral infection, pulmonary embolism, all of them will occur. So diagnosis, clinical diagnosis is there, confirmation by methylene blue preparation, low for medium, and toxic studies, which is ETEC test. So hospitalized, close monitoring of cardiac respiratory function, isolated, diphtheria antitoxin, specific treatment. You give 400 to 6000, you keep on increasing. For pharyngeal disease, less than 24 hours. For nasopharyngeal, you give increased, and a lot for 3 days of illness, diffused bull neck illness. So it can have reactions, anaphylactic and serum sickness. It can have. It must be given as early in the course of this day as possible without awaiting the result of sword swab. Antibiotics can be given concurrently, and they remove the source of infection, benzyl penicillin, 2 weeks. and erythromycin, penicillin or erythromycin. Tracheostomy for respiratory distress. Immunization, DPT or DT. Contract prophylaxis, penicillin B 600,000 IM or oral erythromycin half a gram for 7 to 10 days. And that's how you treat Conobacterium diphtheria. Undone. Seemingly I'm not seeing any Conobacterium diphtheria. Okay. No, tetanus very easily. They just come in then. This happens in condition to Clostridium tetani through a contaminated wound. Clostridium tetani, soil derived from animal and human excreta. Contamination of umbilicus dung, hygiene practices with dung, circumcision. Tetanus neonatorum. So incubation is 6 months. Pathogenesis, spores germinate only in anaerobic condition. In future, lockjaw will be there. They will be smiling. Officer tonus will be there. Severe disease, painful, violent reflex spasm. Can be spontaneous or may be induced by stimuli such as movement, noise, illness. Laryngeal spasm, deadly. Autonomic involvement, cardiovascular complications. So death. Local tenderness will be there. Cephalic tenderness will be there. Usually fatal. Neonatal tetanus, fatal. Then rarely isolatable from wounds. Phenothiazide, overdoses, triacin poisoning, and all stuff like that. So care of tetanus, you care the wound, human tetanus antiglobulin units, and you provide vaccine. That's it. If it's established, you prevent further toxicity, general support, control the spasm, benzodiazepine, diazepam, intubation and mechanical ventilation, MGSF4 infusion, antibiotics and antitoxins, benzyl penicillin, and neutralization of absorbed toxin, human tetanus, immunoglobulin. And next you move on to, we don't do anthrax. Plague also not require botulism toxins. It's okay. Whooping cough, but this is yeah, they may ask, but what is this? I just remember it as whooping cough. Violent cough is there, after days, highly contagious, spread by droplets, 90% within less than 2 years. Catarrhal phase, paroxysmal phase, convalescence phase. Catarrhal is upper respiratory catarrh with rhinitis, lacrimation, low grade fever, and unproductive cough, 1 to 2 weeks. Paroxysmal, you first notice the whoop, which is classic inspiratory auditable whoop due to rapid inspiration against a closed glottis at the end of paroxysm. Only in younger patient, in lumen of respiratory tract is lumen is narrowed due to mucus secretion and mucus edema. Usually terminate in vomiting. Early paroxysmal stage is also infectious. Other features are conjunctival suffusion and petechiae and ulceration of frenulum of the lung. Lymphocytosis is also noticed. Lasts for about 2 weeks, associated with many complications like apnea, bronchopneumonia, atelectasis, bronchiectasis, rib fracture, pneumothorax. Others you have encephalitis, convulsions, conjunctival hemorrhage, subdural hematoma, direct lingual hernia, rectal persists for several weeks to months. So clinical diagnosis not difficult. Whoop is there, blood peripheral nasal lymphocytosis. Gold standard is culture of national NS by PCR array and direct fluorescence antibody. So management, you provide antibiotics, erythromycin, give CDC, give trimethoprim, sulfametoprim. Cough suppressants are not effective. However, oral steroids, antihistamines, beta agonists, and immunoglobulins are also not effective. Only trimethoprim and erythromycin can be given, which is effective. Isolate the patient, chemoprophylaxis. Immunization with DPT prophylaxis. Okay. Bacilli. So boiling or chlorination of water, pasteurization of milk destroy the bacilli. Typhoid fever, acute systemic illness caused by Salmonella typhi, known as Salmonella enterica typhi. Parathyroid is similar, but it is milder disease caused by paratyphy A, B, or C. So humans, the only natural mode of transmission, mouth with feces, marrow, spleen, gallbladder, liver, and cause massive bacteremia. They are sometimes in intestine. They are localized to pairs beta and lymphoid follicles of the terminal ileum. They provide inflammation and plateau-like elevation of pairs patches with characteristic oval typhoid lesion. So clinical features: gradual and non-specific. Headache, fever, abdominal pain, bloating, nausea. Fever rises in a step-ladder fashion, 40 to 41 degree in 4 to 5 days. Hallmark is continuous persistent fever lasting 4 to 8 weeks in untreated patient. Early manifestations like constipation and mild diarrhea. In adults it is constipation, in children it is mild diarrhea. So physical finding: early stages, abdominal tenderness, hepatomegaly, lymphadenomegaly, scanty macropapillar rash. Toe spots are found. Rose spot or red rose spot are macropapillar rash on skin that blanch on pressure on chest and abdomen. Occur during first week, usually for 2 to 3 days. Result from bacterial embolism, and salmonella can be cured from biopsy of these lesions. Then you have mild hepatomegaly. Spleen is soft and palpable 4 to 10 days. May be accompanied by tender hepatomegaly. Then relative bradycardia is there. Pulse is often slower. Intestinal manifestation: constipation is succeeded by diarrhea and abdominal distension with tenderness in the right iliac fossa. Stools are loose, greenish in color, and characteristically pea soup. Intestinal complication develop in third to fourth week. If untreated by end of second week, patient may be profoundly ill. Toxemia, third week they will develop coma and die. Toxemia will happen, and fourth week illness characterized by gradual improvement. So yeah, basically it becomes enters the blood and becomes massive bacteremia. So complication of course bacteremia is happening. General complication: toxemia, dehydration, DIC, intestinal like perforation, hemorrhage from ulcer, neurological muttering, delirium, seizures, coma, meningitis, encephalitis, GB syndrome, peripheral neuritis, deafness, and then endocarditis, pericarditis, pneumonia, cholecystitis, glomerulonephritis, osteomyelitis, everything happen. Dermatitis, osteomyelitis. Carrier state also is there. In about 10 to 10% will continue for several months, and they are termed covalescent carriers. So laboratory investigation: total leukocyte count, leukopenia, relative leukocytosis, eosinophil absent. So blood culture you do gold standard. First week in 90% of the patient it remains positive till fever subsides. So we provide antibiotics, and during early phase bone marrow culture is more sensitive. Early phase stool culture is invaluable in third week. Urine culture remains in 25% till fourth week. So vital test you do: measures agglutination, O antibodies against O, H, and VI antigens of Salmonella typhi and H antigen of paratyphi. Lacks sensitivity and specificity. Viral test becomes positive from end of first week till fourth week. False positive also may be there. False negative also may be there. VA alone is detected in carrier stage. Then we have other serological tests: rapid diagnosis with higher sensitivity, molecular method PCR against flagellin, somatic gene, or VI gene. So going on treatment, we generalize treatment: antibiotic therapy. So you have almost all the antibiotics, but ceftriaxone, chloramphenicol, amoxicillin, chlorinoxazole is the most important. Ciprofloxacin, all of them you can give actually. Cefixime also you can remember. Okay, all drugs which you think are normal you provide. Then multiple drug resistance strain also there. They are treated with ciprofloxacin. Nalidixic acid resistant Salmonella typhi. Ciprofloxacin, ceftriaxone. Corticosteroids in patients with severe toxemia, CNS manifestation, and DIC. Treat the complications. Intestinal perforation, hemorrhage are managed accordingly. Carrier stage asymptomatic, you take chronic carriers, you take gallstones. If there are any problem, you remove that, and given ciprofloxacin, ampicillin for 4 weeks. Prevention: improve sanitation and living condition. Vaccination you give. inactivated injectable typhoid vaccine is available. 3 available. So heat killed phenol extracted whole cell vaccine and VI polysaccharide, and TY21A live attenuated vaccine containing TY21A. Okay, that is it with typhoid fever. You're done. Leptospirosis I didn't do. Okay, moving on. Do we want to do topics? Amoebiasis and malaria is one important thing. I'll just review this. Infectious and dengue fever. Sigilosis is here also. Okay. Sigilosis I have to finish. Amoebic colitis is main. Brucellosis I'll do it once. Cholera no need. I can write on my own anyway. So still I remember. Leprosy, honestly, I don't want to learn. Ill syndrome, yes, leptospirosis. And no infection. Dengue treatment. Dengue management I'll learn. Etiology on my own. Shigella, this also will take some 5 minutes. And chikungunya, no. Flu I have to. And finally, rickettsial disorders. Okay, I can finish it in 45 minutes. But honestly, I just what else is left? But I want to finish dysentery at least. Dysentery and maybe dysentery. Anthrax, okay, leave it. Leprosy also I'll try and finish it off. Leptospirosis I'll finish it off. Dengue treatment I can finish. And malaria is one small thing which I wish I could have done this faster, man. So infections, living infections, psychiatry, geriatrics, tomorrow morning only I can do. Stroke and cerebrovascular diseases is a little bit of a tough one. Tomorrow morning only I want to do that. I don't want to do today, no. Geriatrics I'll do tomorrow morning. Respiratory system I'll do tomorrow morning. AKI, CKD. Infectious I'll finish off today. AKI, CKD I'll finish off. Psychiatry, fuck psychiatry. And dermatology, whatever I remember from previous time when I studied, I'll write. Stroke and cerebrovascular disease, yes, I will do. Meningitis I'll do. Meningitis, stroke and okay. Let me just write this down. Okay, so meningitis, stroke, CKD, AKD, and do as much review. CRS, geriatrics. This much I can do in 2 hours, yes, easily. Okay, so going on with shigellosis, it is bacterial dysentery, acute necrotizing infections, distal small bowel and colon, mostly by one of the Shigella species, and most common causes of bloody diarrhea. Produces toxin, exotoxin as well as endotoxin, cytotoxic, neurotoxic, enterotoxic effects. Source is humans are only natural reservoir. Mode of by ingestion of fecal oral route, contaminated food and water. Incubation period is 1 to 3 days. Severity of infection. Disease varies from mild to severe. S. Sone produces mild infection. S. flexneri infection, usually more severe. S. dysentery may produce fulminating infection resulting in death within 48 hours. So symptoms start 24 to 48 hours after stool culture is required. Sigmoidoscopy, red swollen mucosa covered by mucopus on the surface. Enzyme Shigatoxin, PCR for cellular DNA stools. Rectal polyps, toxic colonic perforation is there. Extraintestinal bacteremia, meningismus, transient peripheral neuropathy, Ritter syndrome, HUS, and TTP. All of these are complication. Megacolon, toxic megacolon, rectal polyps, colonic perforation, bacteremia, meningitis, seizures, transient peripheral neuropathy, Ritter syndrome, which is thyroid, and hemophilic uremic syndrome, and thrombotic thrombocytopenia. One second. HUS. We need to learn about HUS. So, fluid electrolyte, you have to provide antibiotic therapy, you have to give ciprofloxacin for 3 days. Cephalosporin, second generation azithromycin, and ceftriaxone. Antidiarrheal medication should be avoided. Codeine or lopidamine can be given if there is no dysentery. So pathogenesis, yes, you have cysts will be formed, release of trophocytes. Basically, it will come into the body, it will release trophocytes. Trophocyte will become amoebiasis. Okay, this is for amoebiasis. Amoebiasis will amoebic ulcers will be there, invasion into the this thing. Extra intestinal lesions also can be formed. Encystation will occur when it is passing through the bowel. It's passed in the area, passed in semis-formed stool. Trophocyte discharges and undigested food. Pre-cyst, nose to spherical noses. It forms, it secretes through the cyst wall, basically. So there are two forms, cyst and trophocyte, and one is stored and one will get excreted very fast. One will die very fast. One will be resistant to infection and resistant infective. Trophocytes are not infective. Cysts are infective. But so trophocytes cause a lot of damage and have extraenteral spread. It is an infection caused by Entamoeba histolytica. You have trophocyte stage, pre-cystic stage and cystic stage. So trophocyte stage, it's seen in the stool of patient with acute symptoms. Pre-cyst in colon develops into a cyst and it becomes finally a cyst, and it is excreted only in the stool. Spherical thick chitin wall, 4 nuclei, and humans are the only reservoir. They acquired by fecal-oral route through ingestion of contaminated. Incubation is 2 to 6 weeks. Amoebic colitis have amoebic dysentery and non-dysentery amoebic colitis. So dysentery, cysts are passed, cysts can contaminate, so they are viable for weeks to months. They are destroyed in high temperature though. So amoebic dysentery results from ingestion of fecal-oral route of E. histolytica cyst, colonize the epithelial surface of terminal ileum, undergo further nuclear division, release trophocyte. They are carried to the large intestine, may colonize any part of the large intestine, frequently in the cecum and ascending colon causing amoebic colitis. Flash set amoebic ulcer with a narrow neck and broad base. These patients pass both cysts and trophocytes in the stool. Amoebic infection remains subclinical. Antibody response usually occurs even without invasion. Asymptomatic patients should be treated to prevent transmission of infection to others, development of amoebic colitis at a later stage. So amoeboma is also formed. It is granuloma which presents as a palpable mass in rectum or causes a filling defect in colon on radiography. Amoeboma may be formed. Most often it's subclinical even without the invasion. Okay, trophocyte may penetrate and reach liver and they form liver abscess. 40% of patient will have liver abscess. They can also travel to lung and brain. So clinical features, they may produce dysentery of varying severity, foul smelling, offensive, loose water stool, contain mucus and blood. Other symptoms include abdominal pain, especially in the right lower quadrant, which may stimulate appendicitis. Flatulence and weight loss will be there. Clinical examination, tenderness over the cecum, right side. Amoebic typhoiditis, ascending color on the left fossa, amoebic or Manson-Burr point, and tender hepatomegaly. So complications, microscopic examination of the stool will get amoebic cysts. But motile trophocytes containing RBC, hematophagous trophocytes, confirm. Sigmoidoscopy, flash-shaped ulcers. Serological test, hemagglutinin test, indirect hemagglutinin test, ELISA or contour electrophoresis. Amoebic fluorescent antibody is positive in about 90%. E histolytica and DNA in stool sample. So diagnosis for non-clinical suspicion for amoebic liver abscess. Non-dysenteric amoebic colitis is represented as recurrent bouts of diarrhea with or without mucus but without any visible blood. Stool examination, E histolytic cyst or not non-hematophagous trophocyte with no ingested. This is the hopefully it's go okay. There's like bacillary dysentery is a lot more. Amount of stool is copious compared to small. Offensive smell will be there, blood and mucus will be there, no feces, mixed with feces will be there, dark red, it will be bright red, acidic, non-adherent to the container, adherent to the container. Microscopically, RBC will be there in clump, it will be discrete or Rolex. Pus cells will be few, there will be numerous. Macrophages will be very few, ghost cells also few, but there will be numerous here. Eosinophil will be present, it will be scarce. Causative agent is E. trophocyte, whereas here it is moral bacteria. Charcot-laden crystals will be present, however, it will be absent in bacillary dysentery. So use of metronidazole, amoebiasis, giardiasis, Trichomonas vaginalis, anaerobic bacterial infection, pseudomembranous enterocolitis, ulcerative gingivitis. So invasive intestinal amoebiasis, metronidazole you give 3 times a day for 7 to 10 days, or long-acting nitroimidazoles like tinidazole or nidazole. After treatment, extensive 4 species Brucella, goat, camels, botus, or suis and canis. Ingestion from animals, milk, uncooked meat. Usually they should pasteurize, but some if they don't, then you get it from them. Direct infection, urine, vaginal discharge, uterine products, etc. may act as source. Inhalation, aerosol like pens, slaughterhouses and all, conjunctival splashes, injection, etc. Person to person is very rare, particularly mother to child. Okay, so clinical feature involve many organ systems. Insidious onset, it is also called as undulant fever. Acute, less than 2 months, 1 to 3 weeks. Acute onset, 50% case, present with fever, malaise, headache, chills, stuff like that. And myalgia, weight loss, analgesia. Fever, classically high, swinging undulant pattern with rigors, continuous intermittent pattern. Physical findings, non-specific, splenomegaly, lymphadenopathy, hepatosplenomegaly, sacroiliitis, arthritis. Subacute, 1 to 2 months, similar to acute but less severe, chronic, slow grade fever, easy fatigability, myalgia, arthralgia. Basically everything will be there, but nothing specific. Undulant fever, which does not reduce at all. Neutrophil depression may be seen. Splenomegaly is observed. Bone joint complication are common complication. uveitis, sacroiliitis, iliitis, peripheral arthritis, osteitis, bursitis, bone and muscle. So diagnosis, you have culture, isolation of Brucella, better tolerance in Brucella agglutination test, 4-fold or greater rise in titer. IgM is highly sensitive, suggestive. Other tests, CT, MRI, bone, radioisotope, PCR. So treatment you have important one. It leads to septal perforation, nasal collagen. It will come out. Anterior chamber of the eye, keratitis, side to side blindness. Testis is usually involved, leading to destruction of seminiferous tubules, infertility, gynecomastia and all. Painless. Okay, so going on. Diagnosis of leprosy, clinical diagnosis, slit skin smears, and nasal secretion, lepromin test. Lepro Wheels disease. Which one did I do right now? Psoriasis is done. Leprosy. Anthrax, leave it. It's just small thing. Anthrax, it went off already. Again, it's caused by Bacillus anthracis, spore transmission with infected animals, herbivores, occupational disease in farmers, butchers, and dealers. Incubation in 1 to 10 days. Skin lesions will be there, malignant pustule will be there, chance surrounded by blebs. Most common type of anthrax, inauguration as well, sexual occupation as well. Small itching erythematous micropapilla and edematous hemorrhagic base. Painless. Self-limiting illness. And inhalational anthrax is extremely rare and it's very much Wilson's disease, bioterrorism, meningitis. Without rapid and aggressive treatment, death is common. Ingestion of uncooked contaminated meat products, gastrointestinal and severe gastroenteritis, toxemia, shock and death. Demonstrate the organism, smear of fluid taken from edge of skin lesion, culture with other body fluids, serological ELISA for detection, chest x-ray, bronchopleural pleural effusion, treatment, ciprofloxacin. The flexing human monoclonal antibody against the protective antigen has been shown improves inhalational anthrax. So prophylaxis, ciprofloxacin and doxycycline, vaccination, animal and persons at risk, burn, animal dies. That's enough. So few more topics are left. And leptospirosis, Gates syndrome. Yeah, it's done. Leptospirosis, wheel syndrome, malignant falciparum malaria, hookworm and filariasis, if possible. Smallpox, herpes zoster, yeah, same thing. Mumps, no need. H1N1 I will do because I feel that they've asked that and I haven't studied that as much as I wanted. Diarrhea is dengue. I had dengue, so I genuinely think I can do it very, very fast. But the biggest problem right now is leptospirosis. Globally important zoonotic disease caused by spirotrichae. Autumn fever, 70 fever, cane field, swamp fever, Wales disease, stuff like that. 2 species, pathognomic interference and saprophytic free-living bifida. So, interference is leptospirosis. Most widespread zoonotic disease, it's coming from wildlife and in many domesticated animals. Reservoirs are rodents, foxes, skunks, dogs, and domestic livestock. Shed the organism into urine in massive number. Infection is asymptomatic in these patients. Outbreak may occur with flooding. So direct contact, human infection, direct contact with urine or tissue of an infected animal. Transmission may occur through cut, subbraided skin and mucous membrane, nasopharynx, oral membrane, conjunctiva, vagina. Prolonged immersion in contained water also favors invasion. They can survive for months and up to 24 hours in seawater. Ingestion of contaminated water, soil or vegetation. Incubation period is usually 1 to 2 weeks. Pathogenesis. 2 phases. Biphasic illness. Leptospiremic, first phase, because leptospira are present in blood and CSF during this phase. After entry of organism into the human, they proliferate and disseminate through the blood through all organs. Second, you have immune phase. Antibody appear and leptospira disappear from the blood. Organism persists in various organs including liver, lung, kidney, heart and brain. This is the 2 types of leptospira. You have anecteric leptospirosis and ecteric leptospirosis, which is wheel syndrome. Anecteric, you have leptospiremic, and the second you have immune response, whereas in wheel syndrome you have leptospiremic and immune syndrome afterwards. This is shorter duration. This is a little bit of no. This is a longer duration. This is both the same duration, but the symptoms are apparently different. Leptospirosis in blood, CSF, and urine. This is how it will be present. But in icteric, jaundice will be there, hemorrhage will be there, renal failure, and myocarditis is there. Whereas in non-icteric, meningitis will be there, but uveitis more myalgia, headache, abdominal pain, vomiting, etc. All those things will be there. So clinical features: most patients with mild leptospirosis are asymptomatic and do not require medical attendance. Leptospiremic phase lasts for up to a week. Non-specific illness commonly incurred symptoms include fever, severe headache, myalgia, conjunctival suffusion or congestion. Other features include anorexia, nausea, vomiting, abdominal pain, cough, pharyngitis, hepatosplenomegaly, and skin rashes. Immune, you have leptospiremic phase followed by a period of apparently recovery, and symptoms worsen again for 2 to 5 days. Second phase, meningitis, iridocyclitis are more common. Meningitis, presence of headache and neck stiffness may suggest meningitis. 7 days of illness, although organism may be seen. Onset of antibody in the serum is 90% of the patient with abnormality in the CSF. Include change in consciousness, encephalitis, cranioparesis, and acute dilatation of gallbladder with cholecystitis. Then we move on to Wheel syndrome. It is a non-specific group of leptospirosis, indicates severe leptospirosis developed during second immune phase of leptospirosis and also progressive illness. Components: you have jaundice, you have renal failure, hemorrhagic manifestations, pulmonary syndrome, CNS, DIC, hemolytic anemia, myocarditis, arrhythmias, MODS. All of them will be there. Purpura, petechiae, oral vaginal conjunctival mucosa, bleeding, epistaxis, hemoptysis, hematemesis, and melena. Thrombocytopenia is common. Renal failure will be there, jaundice will be there. But wait, here you have fever, headache, myalgia, conjunctival system. Immunological phase, you have meningitis. That is the only thing. Present Wheel syndrome, which is icteric leptospirosis. You have additional hemorrhagic manifestation and renal failure. Pulmonary syndrome, CNS, meningoencephalocele will be there, DIC, hemolytic anemia and all will be there. Whereas here it will not be there. Conjunctival suffusion and fever will be there. That's it. But it will be present to what? So urine examination, early part of the illness. So microscopic hematuria, pyuria, and proteinuria. Demonstration of organism: tightly coiled spirotric may be visualized in urine by contrast or dark field microscopy. And blood, you have total leukocyte count may vary. Polymorphonuclear leukocytosis, neutrophils more than 70%, which shift to left is very frequent. Anemia, thrombocytopenia in severe infection, elevated marker of inflation, inflammation, raised ASR and CRP, raised BUN and hyperkalemia. Coagulation studies, CK creatine phosphate in 50%. Liver function test show AST, ALT raised up to 5 times normal. Chest radiography, patchy bronchopneumonia, small pleural effusion may be there. Electrocardiographic abnormality like bradycardia, low voltage, and unspecific ST wave. CSF examination may be there, 90% of the patient. Cell counts increased with predominance of neutrophils. Serological tests, you have IgM antibodies. IgM ELISA you can do, demonstration of leptospiral antigen by radioimmunoassay or ELISA. Culture can be confirmed by Felcher's medium or leptospiremic phase or during CSF during leptospiremic phase. Illness or of the urine from this can be converted can be takes several weeks. Culture can show detection of leptospiral DNA by PCR in blood during early symptomatic disease and urine in 8th day of illness. You have modified phase criteria, which is right here. Headache, fever. Just remember them. Honestly, this one is too complicated. Anyway, antibiotic therapy, susceptible to broad range of antibiotics. Mild disease, doxycycline, ampicillin, amoxicillin, azithromycin. Severe leptospirosis, you can give IV penicillin, ceftriaxone, cefotaxime. Treatment or complication or general care of the patient. Blood may require transfusion or hemorrhage, anemia. ARDS require mechanical ventilation. Renal failure, dialysis, IV corticosteroid. Transfusion, hemorrhage, ideas, mechanical rotation, and repair correction. Then we have mumps, infectious mononucleosis, chickenpox, and let's just read off swine flu very fast. It is influenza cases caused by orthomyxovirus, endemic to pig population, influenza C or various subtypes, and swine influenza H1N1 reported in 2009 Southern California and Texas. Respiratory disease of pigs caused by type A influenza virus that regularly causes outbreaks of influenza in pigs. High level of illness but low death rates in pig campaign. Disease originally nicknamed swine flu because of its virus that is originally linked to humans from pigs. Virus is a resultant, a mix of gene from swine, bird, and human flu viruses. Droplet from cough or sneeze, object contaminated by cough. Signs: patients above 65, patients children below 5, pregnant women. Underlying medical condition: weak immunity, or at high risk of serious complication. Complication: ARDS and MODS. ARDS, MODS. Dysfunction syndrome and acute respiratory dysfunction syndrome. High-grade fever, unusual tiredness, headache, running nose, sore throat, shortness of breath or cough, loss of appetite, aching muscle, diarrhea or vomiting. Diagnosis confirmed in case of novel. Real-time PCR. RT-PCR, viral culture from swabs. Nasal oral secretion of respiratory tract can be used for virus isolation. Treatment is mainly supportive, severe cases, IV hydration, and other supportive measures. Antiviral agents we consider for prophylaxis: neuraminidase inhibitor. Release of virus from infected cells decrease the spread of virus. Neuraminidase inhibitor agent decrease the release of virus from the infected cell, thus decrease the spread of virus. Drugs include oseltamivir, zanamivir. Both are effective against influenza A or B. Inhibit H1N1, hyaluronidase and neuraminidase. If neuraminidase, if you attack, then it doesn't work that much. Oseltamivir, zanamivir. 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 Vaccination, yearly vaccination, species-specific strain. Oseltamivir, zanamivir. Oseltamivir, zanamivir. Oseltamivir, zanamivir. Oseltamivir, zanamivir. Oseltamivir, zanamivir. Finally, protozoal infection. Okay, just a second. Infectious mononucleosis and mumps I didn't do. Chickenpox and HCV also I didn't do. Leptospirosis is done. Dengue hemorrhagic fever also I didn't do. How did dengue hemorrhagic fever not come here? 10 pages. Non-severe and severe dengue. Plasma leakage, hemoconcentration, bleeding, and organ impairment. Functional endothelial activation or dysfunction. For fever, one is fever and hemorrhagic manifestation. Grade 1 plus spontaneous bleeding. Grade 1 and 2 plus circulatory failure. Narrow pulse pressure, weak pulse, less and hypotension, restlessness. Grade 3 with profound shock with undetected BP and no pulse. Thrombocytopenia with less than 1 lakh cells. And HCT more than hematocrit rising. Dengue fever, dengue hemorrhagic fever. That's it. Febrile phase is there. 2 to 7 days. Critical phase. Then there is a recovery phase. You don't give massive fluids. Tourniquet test is one thing. You inflate to 80 mm for 5 minutes. Measure the number of petechiae that appears in the circle. Mark a circle of 5 cm diameter on flexor aspect arm. Yeah, that's an interesting thing. Saddleback fever, mild hemorrhagic manifestation, petechiae mucus, normal bleeding, liver enlargement. Etiology, pathogenesis, you can see. Blood, you have isolation of dengue from virus, detection of dengue virus RNA. NS1, you have to do IgM and severe dengue stepwise. Stepwise management is there, investigation, CBC and all. Fluid intake, control fever, bring to hospital immediately. I have to do overall assessment, treatment of IV fluid, hematocrit. Avoid intramuscular injection unless ARDS can be withheld in plasma transfusion is there. Control on mosquito. Currently no vaccine is available. Okay, now dengue it's okay. very briefly, if you remember from Dr. Pittman, basically, you have to know that the more number of times you get infected with dengue, the worse it is. And dengue 2, then followed by 4, or dengue 2 followed by 3 is the most dangerous. So dengue also somehow I have done enough. Only thing left is AKI and CKD. And of course, the main thing, malaria. Honestly, I think I'll not do malaria. I'm thinking about ending this right now. I'm genuinely tired. First of all, I'll do malaria on my own. Then CKD, AKI, AKD. Tomorrow morning at 5 o'clock, I'll wake up and I'll do off.